You're listening to Medscape's In Discussion series on bipolar disorder, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Trisha Suppes. Dr. Suppes is a professor of psychiatry and behavioral sciences and the director of Exploratory Therapeutics Laboratory at Stanford University School of Medicine. She also serves at the Palo Alto VA as director of the Cooperative Studies Program Network of dedicated enrollment sites and a staff physician. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Trisha Suppes, and welcome to the Medscape in Discussion Bipolar podcast series. Today we'll discuss new and upcoming treatments for bipolar disorder, with also some focus on the areas of research in bipolar that my guest has especially been interested in for many years. First, let me introduce my guest, Dr. Roger McIntyre. Dr. McIntyre is known to many of us. He is a professor in the Department of Psychiatry and Pharmacology at the University of Toronto and chairman and executive director of the Brain and Cognition Discovery Foundation in Toronto, Canada. He also has some important university affiliates, both in the U.S. and in China and Korea. Welcome to In Discussion podcast.
Yeah, fun to work with you on and have this discussion.
Yeah, I had a few minutes and I spent some time going back over some of the publications, and I really found there were three themes in particular that really I saw, and I think you'll easily recognize them. The first was treatment, then comorbidity, and in particular some recent focus on the impact of obesity, inflammation, and then also mechanism. And one of the things to me that is striking about your work, you're never disconnected from the patient. I feel that your work in general is driven by your awareness of what are the critical issues to the patient. And I think that focus is very much appreciated. So I'm wondering, what are you focused on right now? Like, what kinds of things are catching your interest? I'm sure it's probably in these three categories.
Well, first of all, Trish, just to react to what you said, I'm pleased to hear that because, frankly, I would say that I don't think I could come up with a single example in my entire career of a research idea that I began to gestate or marinate that didn't happen when I was sitting talking with a patient and or their family. And so many of these ideas are derivatives of just seeing patients. And I think the way you described it is really where I land today. I remain extremely interested, I know you are, Trish, as well, aspects of phenomenology. Where's the line between, there is one, between unipolar and bipolar disorder. I remain especially interested around the issue of comorbidity broadly defined. And I think now, Trish, as you know, we have just shy of half a dozen classes of treatments that are often prescribed in bipolar disorder, but none of them, including lithium, was originally developed for bipolar disorder. We've been in the business of repurposing. I don't know about you, but when you're like the youngest kid, you always get the hand-me-downs in the family. And so bipolar has always gotten the hand-me-downs. It's always gotten the medications that were developed somewhere else and then got, repurposed in bipolar disorder. And so I think there's been a real interest in, are there insights that we've gathered with respect to a mechanistic basis of understanding the disease of bipolarity? And can that really then position us to offer therapeutics that are mechanistically informed? Wouldn't it be cool one day to say these treatments modify the disease? And that's where I'm really finding myself particularly passionate.
So focusing on mechanisms, that is a very interesting topic in that I don't know that we really have a clear understanding of fundamental mechanisms 70 years on from when lithium was reintroduced to the world in the early 50s. But what's your perspective on that, either what you're seeing or what your hope for the future is?
Yeah, and I think that your comment is certainly very much where I land on this. I think this is still aspirational. In other words, I agree. I don't think we still at this point in time really have a real refined, discerned understanding of what the mechanism is. We have clearly some leads. And I think that, as you know, Trish, bipolarity has over the hundreds of years, it gets put into a bucket. And then we take a kind of a spectrum approach to it. Then we want buckets again. Then we said, no, it's a spectrum. I'm not sure what the reality is, but we love lumping and splitting bipolarity. Whatever it is, certainly there's sub-phenotypes or phenotypes. For example, areas of cognition or areas of reward like anhedonia, at least taking that type of approach, I think there's a better characterized underlying mechanism, or maybe better to say a little less poorly characterized. And I think from that, we've actually got some targets, whether those targets are derivatives of our infatuation with monoamines. As you know, there's been a lot of interest in psychedelics, even in bipolarity, but maybe getting into inflammation, maybe it's metabolism, maybe it's bioenergetics. And so I think we're a little less non-informed, but I do think it's still an empirical and iterative campaign.
I really love how you put that, because without directing our attention to it, no progress will be made. And anhedonia, I think, is particularly an interesting focus because there's some understanding of the neural pathways or the neural connectivity that underlies anhedonia, and people are looking at ways to shift it that are somewhat novel. And to me, that makes it an interesting target and very common in bipolar depression, of course. So that's interesting. So, I think the, quote, spectrum, which I have mixed feelings about, as a particle and a wave. So depending on how you're looking at it, it's a particle or a bucket, or it's a wave. So it depends where you're looking at it and how you're looking at it. But I absolutely agree with what you said with that. It's not clear to me that helps us. And I think you're getting into more of the sort of fundamental elements that people experience, not just depression, which is probably 8 different things or 10, but aspects of something like anhedonia. What's your view these days on inflammation and the role that it's playing or may play either as causal or secondary during bipolar disorder episodes?
Yeah, I think that the evidence that it's causative in bipolarity, much of that is circumstantial. Much of that is still, I think, hypothetical. I do think that there are some lines of evidence that one could say, this is not just association. This has causative elements to it. And I think that's probably true. The way I think about this, Trish, is I think more and more, this is a big jigsaw puzzle, and there's many, 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 many pieces to this puzzle. It would be a very defensible, coherent, and viable hypothesis to work with that one of those jigsaw pieces is inflammation. What we're talking about is in medicine, and you know this, what we have done is we've tried to reduce the chaos. We've tried to reduce the entropy of the mechanism. So we pretend like serotonin operates in a sort of orbit by itself. Clearly, all these systems are interconnected. Now, nobody gets a bonus mark for making it more complicated. It's complicated enough. So when we talk about inflammation, we are already talking about glutamate and GABA and serotonin, and we're talking about plasticity and neurogenesis and apoptosis and all that good stuff. And all of these mechanisms are posited as playing some role. They're part of the jigsaw puzzle. So I guess in some ways, is there a way that we can think about treating bipolarity that gets closer to the lesion, as we say, that is able to affect a thread that's causing this illness, but also tugs on other threads that may be implicated as well? I think what's interesting, Trish, is 2 years ago, the FDA approved dextromethorphan bupropion as a treatment for major depressive disorder. That's not bipolar disorder, but where I'm going with this thought is that dextromethorphan is actually a sigma-1 agonist. And what's interesting is it has a robust effect on insulin signaling. It boosts insulin signaling. When you take dextromethorphan, it augments GLP-1, which is a big topic now in metabolism. It reduces inflammation. It's a potent anti-inflammatory. So we already have treatments that are in the zip code of inflammatory modulation, metabolic inflammation. But the street light shines on one particular actor. Is it glutamate? Is it serotonin? I think we're around there now. I just think that we need to refine it. And in the area of bipolarity, there's plenty of reasons to argue that targeting the system doesn't have to do with the medication. This could be with exercise. It could be through mindfulness. As you know, a lot of folks interested in gut biome manipulation. It could be through other medicines that haven't been created yet. They could be de novos that are possibly beneficial. And to go back to what we said earlier, I don't know if it's just being in the business so long, Trish, but when you start off, you have this childlike, or I had a childlike, I'll speak for myself, thought that we could just treat it all. But then now where I land is a bit like in the world of cholesterol. If someone came to me and said, hey, Roger, I have a treatment that can help LDL cholesterol, really bad cholesterol. Are you interested in that? Absolutely. So using that as the metaphor, if someone had a treatment that was really pro-cognitive and really, really helpful for anhedonia, would I be really thrilled for bipolar therapy? Absolutely, I would be. Getting a bit more strategic on how we target this. And inflammation, and I think metabolism, represent very viable and coherent and rational targets.
Yeah, I totally agree with that. And I think, whether, for example, obesity / inflammation, because we know with obesity, there's a lot of inflammation, right? So whether people who have a genetic or social environment that predisposes them to bipolar disorder, that may also lower their threshold for obesity and other kinds of inflammatory diseases, right? Sort of the chicken and the egg. And, they found with the new semaglutides group of meds, which is actually expanding, as you know, there's a third group coming in. The cardiac benefits they're seeing, which are substantial, are because they're dropping an inflammatory condition. Do you see any role for the semaglutides in treating bipolar, even bipolar depression, let alone certainly obesity?
Oh, I categorically do. And I think that the GLP-1 or glucagon-like peptide receptor agonist type medicines, which of course are better known in the world of diabetes and weight management, clearly have not just near-term, but they actually may even have a more intermediate and long-term and more multidimensional application of bipolarity. In the near term, clearly metformin as an antidote for medication-related weight gain is modest at best. And although the evidentiary base for the GLP-1 receptor agonist certainly has not been accumulated enough, we had some RCTs and so on, this may not surprise anybody. They beat the pants out of any medicine for weight and counteract some of the effects of offending weight gain promoting drugs. But to step back 2 steps, at our center in Toronto, we are looking at one of these agents, semaglutide, as a potential pro-cognitive agent, not using it as an anti-diabetic, not using it as a weight loss drug, using it as a psychiatric drug. The prevailing view is that lithium and antidepressants and ketamine and ECT increase brain plasticity and trophic processes. And we now know that GLP-1 agents, not only they brain penetrant, they get into the brain, but they stimulate neurons. It's really cool. So you touched on this, Trish. I think when we think about bipolarity, we have to think broadly, not just within the brain, but the body. These patients are living a shorter lifespan. They're living a shorter health span. And so if we can help them with fatty liver disease or heart disease or cerebral vascular disease, and these drugs are showing remarkable benefit through their anti-inflammatory, antioxidant pathways, that would be a win-win for our patients who live with bipolar disorder.
That's great you're doing that, because I think we only have this very focused understanding of where they're helpful. But because of their impact on the brain and the body, I think that's great that you're asking that question. Whether they, independent of change in weight, might do other things that could make a big difference for patients and where they live.
This was sort of an observation I made a long time ago. I was sitting with patients. I used to sit and, chatting with your patient, my office, right? I'm sitting there and I noticed that the people who are obese, their social cognition, just like their timing interpersonally, their empathic engagement was a little more off. And then we did a little pencil and paper testing back in those days, and their cognitive testing was worse than people who had bipolar who were not obese. And so, I got really interested in this. I think we're in the brain preservation business in psychiatry. And so what are the threats to brain? Well, one of them is obesity, and through inflammation, insulin resistance, and it decreases cognitive performance, and it negatively affects motivation, hedonic tone. And Trisha, we know this. If you look at what are the most debilitating aspects of bipolar, what's depression? But if you get granular, what it really is, it's the lack of energy, the motivation, interest, they're not engaged.
Given that, you ought to think about whether suicidality would be markedly decreased, because, you're living kind of a difficult life. Maybe the suicidality is not only secondary, it might even be primary. And if you can shift how the brain is engaging with the world, that might affect suicidality as well.
Absolutely.
Well, let me just shift for a moment. You recently developed the rapid mood screener, which I've heard about not just from you, I've heard about it from other people, and that people have really enjoyed it. And I wonder if you could just tell me what led you to develop it and what your thoughts on it are and where people might get it if they're interested in it.
Yeah, and I'll keep it really brief. I think that if I step back and look at bipolar disorder from a population health perspective, I'm still convinced that the misdiagnosis and the delay in the diagnosis still remains such a modifiable problem. And too often, as you know, Trish, patients are ill for years before the diagnosis is even made. And over the last 2, maybe 3, but certainly 2 decades, there's been a number of screening tools for bipolar disorder, and each has its merits. But what I had noticed, this was just an instinct that I had, I think that there was a bit of throwing the baby out with the bathwater. I spoke to a lot of colleagues. They say they don't screen for bipolar because the screening tools are too guilty of false positives. Someone has some other diagnosis like borderline personality disorder as the principal diagnosis, and they screen positive on a screening tool. So we thought, let's go back to the drawing board. Can we engineer a screening tool for bipolar? Of course, the aspiration is a perfect screening tool, but can we do better than the extant tools? In other words, can we improve upon sensitivity, specificity, false negatives, false positives, all that good stuff? And so that was the impetus. And what's different about Rapid Mood Screener, it's not only asking people about hypomanic symptoms and manic symptoms, but ask them about depressive symptoms and some of those famous Robbins and Gouze validators, like the age at onset, how many episodes of illness have you had, response to treatment. Again, they don't diagnose bipolar, they screen. So it triages your time with the patient. And so the impetus was, I think, the juggernaut, we're not getting the diagnosis made timely, accurately. And I don't think there's routine screening, and there's been some pushback with some of the extant tools. So we said, let's get back to the drawing board and do something that's a bit better than what's out there. And I think that's what we created.
Yeah, and I agree with that. I think it's a bit better. And that's not a small thing to get something that's more usable. It's shorter. I think it's more accessible for the patient to understand what's being asked. So where can people find this, if you don't mind my asking? I know you're not charging for it. It's downloadable.
You're correct. It is downloadable. People can find it really easy. Go to www.rapidmoodscreener.com. And it's a screening tool that is intended to be brief, patient-administered, user-friendly, very easy to interpret. And what we attempted to do, and I think we've had some success now, is to build upon the success of other screening tools. And the overarching aim of the Rapid Mood Screener, the RMS, is to identify a tool that could triage patients who may have bipolar disorder. And we're of the belief, and it's supported by some of the metrics, that the performance of the Rapid Mood Screener, the RMS, is an advantage over many of the other screening tools in the sense that it's got better sensitivity and a bit better specificity, a little lower rate of false positives. So we think this can help triage a busy clinician's time at the point of care. We really recommend people use it. It evaluates both manic and depressive symptoms. I think that's critical given how predominant depression is in the clinical presentation of bipolar disorder.
And also, depression as it's currently diagnosed is so heterogeneous, you know. It's like maybe it's 15 illnesses for all we know. I mean, it's one of the reasons I think your work's so important when you're taking things apart, the jigsaw puzzle, which is a great metaphor, because it isn't one disease. Somebody might have predominant inflammatory, someone else might have disruptions in the gut that are contributing factors. There's a lot. So today we've been talking to Dr. Roger McIntyre. We've covered a wide range of topics, but I think some of the highlights have been the focus on looking at all the pieces that may go into mood disorders, not simply looking at the mood itself, but also considering if elements of inflammation or other kinds of dysfunction may contribute to the illness. Clues, I would call them. And I think that's really interesting. He's been so consistent in his focus and his engagement with patients. He has a history, in fact, of being head of the scientific board for the Depression Bipolar Support Alliance. And to me, his work, the patient, is always woven through all aspects of it. We also got to hear a few minutes about some of his thoughts on the newer therapies or what's on the horizon, something to keep our eye on. So I just want to thank you for tuning in. This podcast will be available on the usual platforms, and you may want to download the Medscape app to listen. Please subscribe to this podcast series on bipolar disorder. This is Dr. Trisha Suppes for Medscape in Discussion.
Thanks for listening to Medscape's In Discussion Bipolar Disorder podcast series with our host, Dr. Trisha Suppes. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on bipolar disorder.